This year's meeting, Dr. Cyril Spann. As all of you know, Dr. Spann is a board-certified gynecologic oncologist extraordinaire. Prior to joining Piedmont in 2020, he was at Emory Healthcare for 30 years. He graduated from Meharry Medical College in Nashville, Tennessee. He completed residency in OBGyn at Emory, and then Gyn-Onc Fellowship at UNC, both places I went to. Dr. Spann has over 34 years of experience in gynecology and Gyn-Onc. During his time at Emory, he served as the chief of the Gynecologic Oncology Service at both Emory Midtown and Grady Hospitals. He is a member of the American Board of OBGYN and is a diplomat of the American Board of Quality Assurance Utilization Review Physicians. Dr. Spann served as the president of the Atlanta Medical Association and this very society. He specializes in managing patients with cancer in the female reproductive tract. He has surgical interests in minimally invasive surgery, but I would also like to say that Dr. Spann also specializes in teaching. I would not be surprised, I would not be surprised if he too has likely lost count of the number of times he has been selected to receive an Excellence in Teaching Award. There were at least 9 listed in his CV, but when I looked closely, it only dated back to 2001. So there's lots more. In his spare time, Dr. Spann enjoys to hike, ride his bike, read, and also to travel. On a personal note, Dr. Spann is one of my greatest mentors during my training. Those of us in the room who have had the privilege to work with him know all the sayings that play in our minds to this day while we operate. Suck the smoke, do the Grady roll, look for the cotton candy. It is with great honor that I introduce to you our opening speaker, Dr. Cyril Spann.
Thanks, everyone. So, incisions and gynecologic surgery. No disclosures. So, objectives today, we want to describe proper ways to hold a scalpel to make skin incisions. I see residents holding scalpels all kinds of ways, including at me. Understand that elective surgery is an acceptable method to make skin incisions. Listed 3 types of incisions for gynecologic surgery. Describe proper ways to close vertical fascial incisions and hernia prevention strategies. Describe spinal level of key peritoneal cavity structures, and then discuss post-procedure wound care strategies. For those of you in the room from the Emory in the early days, Dr. Suarez, a good start is a good beginning. Dr. Birch, 1983. So this is a slide that I think I try to put in most of my GYN talks, and it talks about indications for surgery, but surgery is a pyramid, and doing the surgery itself is the very top. But we have to understand the physiology, the reproductive organs, the pathology, why the patient needs surgery, and what the indications are. And then we need to look at the right patient for the right operation, i.e., is she medically fit or surgically fit to have surgery? And then what is the right operation for that patient? Is it a vaginal approach? Is it an abdominal approach? Is it laparoscopic approach, laparotomy, and then actually performing the procedure itself? So let's look at some of the anatomy of the abdominal wall. So starting here at the top, we have the thoracoabdominal artery, the mammary artery coming down, and then it anastomoses with the inferior epigastric artery coming from the external iliac. And then here are your muscles coming through the side. Here's your rectus muscle, and then over here you have your sheaths. This is a deeper view, and here we can see the celiac artery, and what I really want to point out here is where L1 is. So there's a lot happening at L1. L1 is where your pancreas is coming across, and L1 is where your kidneys are going to be. Also, many residents forget where the umbilicus is. So in a normal weight patient, the umbilicus is going to be between L4 and L5. So when we put our trocars in, we need to be cognizant of where we are pointing our trocars to. And then S1 is important. This diagram is a little bit off, but at S1 is where your common iliac is going to bifurcate, and S1 is where your anterior superior iliac spines are. So if you ever get lost during the surgery, you can always go back and feel for your anterior iliac spines, and that is where your common iliac is going to usually bifurcate. Now here's a transverse view of the abdominal wall, and here you have the external oblique, internal oblique, and then this is the transversus. And then if you're inferior to the arcuate line, then the transversus is going to become posterior to the rectus muscle instead of going anterior to it. And this is important because if you make your incision where it's superior to the arcuate line, you need to be cognizant to make sure you close that transversus fascia as well as the internal oblique and rectus fascia and external oblique. Humbling. Most hysterectomy now are done via the laparoscopic approach, robot approach. And let me show you the data for that. This is the NISQIP data. Trans and perioperative outcomes across elective benign hysterectomy procedures from the NISQIP 2007 to 2017. And the reason I put this slide here is because I had no idea it was this dramatic. So here, the blue is for laparoscopic procedures, and you can see starting 2007, the laparoscopic procedure rate has really skyrocketed up to 2017. This is when the data was last collected or last published. And then for your transvaginal route, we've slowly seen a decline. And residents now don't get much training with vaginal hysterectomies. I think it's becoming the domain of the urogynecologists. And then, as you can see, the abdominal rate has also gone down. And here, the lines cross between 2008 and 2009. And if you want to see the raw numbers, here, the trans-abdominal route is 54.3% back in 2007. And then over here in 2017, it's dropped down significantly. Again, the transvaginal route has been a slow decline, also down to 11.3%. And then your laparoscopic approach was 26.5% of 372, the cases counted by NISQIP, and now it's gone up to way above 50%. So when thinking about hysterectomy, we should think about the vaginal route first. So what are the factors that we're going to use to determine whether we perform a vaginal hysterectomy? So we can think about the passenger, which is the uterus itself. If the uterus is over 12 to 14 week size, generally we want to go with an abdominal or laparoscopic approach. I used to tackle uteri a lot larger than this, but over time I realized that it probably just wasn't worth it. The census, patients who've had children are more likely to have a successful or easier route for vaginal hysterectomy if the uterus is able to descend some with traction. Be mindful of the patient who's had previous surgery. Sometimes if patients have had several cesarean deliveries, the uterus will be adherent to the anteroabdominal wall, and that might preclude you being able to perform a successful vaginal hysterectomy. Patients may not be able to tolerate this much in the office, but you can put a tenaculum on the cervix, tug on it gently, and if you see an indentation in the abdominal wall, that'll give you a good idea that the patient has an adherent uterus to the anteroabdominal wall, and you should not consider a vaginal approach. The anatomy, the pubic arch is very important. Patients who have a narrow arch are going to have difficulty getting great exposure, so make sure you assess that in your office, and generally you want that to be greater than 90 degrees. And then concurrent procedures. If you think you might need to do abdominal sacrocolpopexy, of course you want to tackle that with a scope or bilaparotomy. and then training. So if you haven't been trained to do a good TVH, it's probably not a good idea to do it by yourself. Adnexal factors. So you want to look at the historical information in previous surgery. And the older I get, the more I realize you got to have those previous op notes. So if the patient's had difficult procedures in the past and lots of adhesions documented, then you generally want to make sure that you go with a laparoscopic approach or an abdominal approach. Desire for fertility, this is going to impact whether you do the hysterectomy in the first place, and it's going to impact whether you want to save fallopian tubes, et cetera. The size greater than 10 to 12 centimeters with an adnexal mass. I use 12 centimeters because 12 centimeters is the largest diameter bag that I can get my hands on. And then the mobility on the exam, if the mass is not mobile, that means it's going to be adherent to something, and you're going to be more likely to rupture it trying to get it out. And generally our intent is to try to avoid rupture unless you're absolutely certain that it's not cancer. Preoperative and operative imaging, very important. Getting to the point also, I'm getting more and more imaging as I get older. The CT scans can help you identify whether the patient's had a uterine injury on prior procedures, so you don't want to get blamed for a uterine injury that you did not cause. It also may give you an idea whether the patient has cancer, she has ascites or lymphadenopathy. You may preclude, avoid doing the procedure and send the patient to an oncologist. Of course, ascites is a marker for cancer, although patients with endometriosis or MEG syndrome can have ascites without a diagnosis of cancer. Doppler flow. Now, this is extremely important. So generally, when operating on adnexal masses, most of us are going to order an ultrasound. But if you can throw a Doppler on top of that, you can get an idea whether or not it might be malignant. So Doppler flow with the blood flow going around the periphery of the ovary is going to give you an indication that it's probably benign. If you see flow within the ovary, it's more likely to be malignant, but it's not totally specific. And then you also want to look at what the inside of the ovary looks like. Does it look cystic? Does it have septations? Does it have solid areas? And the solid areas are going to make you think more along the lines of a neoplasm, especially malignancy. So I don't know if you can read this from your laptops, but these are several types of transverse incisions. And the midline, I guess, is the granddaddy for surgical procedures. And for gynecology, we generally try to use more and more transverse incisions. So Fannin seals we're all very familiar with because this is what we use, our bread and butter for cesarean delivery. A paramedian incision is an alternative for someone who's had previous vertical surgery, vertical incisions, and you're worried about intestines adherent to the abdominal wall at the site of the incision. So you can make your incision 5 or 6 centimeters lateral to the midline to try to avoid those adhesions. The Joel Cohen incision is, I like to call it an emergency Fannin seal. It's a Fannin seal incision that's a little bit more superior than a regular fan. A Czerny incision is an incision that is 2 centimeters superior to the symphysis pubis, not umbilicus, 2 centimeters to the symphysis pubis, and it allows you to get great exposure to the sidewall and to the bladder. When we did our Birch procedures in the past, this is a great incision for that. This involves resecting the tendon of the rectus muscle from the symphysis pubis. And then Maillard, this incision is approximately 4 centimeters superior to the symphysis pubis, and we transect the rectus muscles bilaterally when we perform this procedure. And then I'll highlight this one a little bit. This is an Alazan hybrid incision, and what it involves is starting off as a Fannin seal, but if you get into exposure difficulties, then you can carry the dissection more superiorly or more cephalad, including the umbilicus. You're going to make the vertical incision on the transversus fascia as you get more superiorly, and you have to be cognizant of closing that fascia. So here are the incisions sort of drawn out. The purple dots here are the outlining the anterior superior iliac spines, And then the red line is going to be where you make your churning incision, is right superior to the symphysis pubis. And then this is the ocelom incision. It's going to be going from the area just medial to the anterior superior iliac spine, dipping down and then going back up again. This is your paramedian, this is your vertical, and then this is going to be your maillard and your jewel colon incisions. It's still a green light, I'm good, right? Okay, so this is your vertical incision for patients who's a little bit obese, who has a tannus. And remember that the umbilicus is going to be more inferior to your anterior superior iliac spine, so just be cognizant to make your incision more superior, and then that way you avoid the laying of the anaerobes. So we mentioned that laparoscopic procedures are becoming more and more prevalent, and I outline here laparoscopic incision sites. So the dark green, these outline the more inferior laparoscopic approach, and the light green are more superior. And I've pretty much adopted this because it allows me to look down on everything. It allows me to stand over here, and I stand on the patient's left side. I have an operative instrument, my bipolar instrument in my right hand. In my left hand, I have a grasper. My assistant has a laparoscope here, which is slightly to the right of the midline, and then the assistant has another port here. Usually I put 10s across the top and then a 5 here, but I like the 10 because I like the 10 scope because it's a little bit more durable and it won't bend. And then this is the more inferior approach. This is going to be right at your navel, the umbilicus. This is where we traditionally make our incisions. But again, I like to look down. I like to look down anatomy. And this is the typical diamond approach where you have a 5 millimeter, approximately 2 or 3 centimeters superior to the symphysis pubis, and then your lateral ports. And this is a laparoscopic procedure where I've got my ports in. This is the one that's slightly right to the midline, right upper quadrant. This is Palmer's point, which is pretty popular, and then this is the 5 millimeter in the left lower quadrant. Oftentimes when I get my pneumoperitoneum, I'll take a Verey's needle and I go right inferior to the rib on the left side. That's a clear area you can get your pneumoperitoneum. You won't have to worry about someone having intestines scarred up to the umbilicus from a previous cesarean delivery. Now, the proper way to hold a scalpel. So for those of you who work in the kitchen on the weekends, this is pretty much the way you would hold a paring knife or a chef knife. And this blade is pretty long. It's got a lot of surface area. So when you hold the blade like this, you get a lot more surface area of the blade on the skin where you're making your incision. So you don't want to hold it like a pencil. And this is using an 11 blade, and notice that the blade is shorter, so you're holding it more like a pencil, and the sharp edge of the blade is towards your hand. And finally, this is the 15 blade. It's nice and pointed and sharp, and when you use it, you make sure that the sharp edge of the blade is pointing away from you and not toward you. Now, incisions, or making incisions. So we showed about using a scalpel. Let's talk a little bit about electrosurgery. So here's a randomized double-blind trial comparing the cosmetic outcome of cutting diathermy versus a scalpel for skin incisions. And coming along, I thought, God, it must be heresy to make a skin incision with a bovie. What type of sense does that make? So they did an assessment of 115 patients. They ended up randomizing 66. 31 got allocated toward electrosurgery. 35 got allocated toward a cold knife scalpel. Several were lost to follow-up for 6 months, follow-up 3 in this group and 6 in this group. And then they were able to analyze 28 and 29. So they use a patient observer scar assessment scale and patient scar assessment scale to help evaluate what the cosmetic results were. And again, there were 28 people, in the electrosurgical group, 29 in the scalpel group, and you can see the p-value was not significant. So there was not a significance in the way the incisions looked after 6 months. And from this study, there's some examples. This is the one with the electrosurgery, the way the scar looked, and then this is the one with the scalpel. And there's not really much difference here, especially if you're looking from the distance. If you're right up on it, you might see some difference. But if you're 2 or 3 feet away, which most people are going to be, right, you're not going to see much of a difference. Here's another study, comparison of electrocardial incision with scalpel incision in the midline abdominal surgery, a double-blind randomized controlled trial. And the reason I like this study so much was that the patient was her own control. So they did part of the incision with the electrosurgical unit, and they did the other part of the incision with the scalpel. So here is the part of the incision that was done with the electrosurgery, and this is the part that was done with the scalpel. And then several weeks later, or 6 months later, this is the way it looked at the end. And you can see there's not a whole lot of difference. There's some difference right here. This looks a little better. But for the most part, they're not much different. With a comparable post-op incision site pain, wound infection rate, and significant lower blood loss, with the equal time taken for incision, electrosurgery can be considered safe and effective in making skin incisions in midline laparotomy compared to the scalpel. Okay, so here's a meta-analysis. People like to look for meta-analysis of systemic reviews when they're trying to decide whether they want to do something, because one study by itself is probably not enough. They looked at 781 articles. They retrieved 66 at the end. 25 articles were excluded after full text screen, and then they ended up evaluating 41 articles. And at the end of the day, the surgical incision using electrosurgery can be quicker with less blood loss. Now, we're not talking about 80 cc's versus 10, and we're talking about 10 cc's versus 5. This is not a big deal. The postoperative pain was not significant. You would think that the pain might be more with electrosurgery than for cold knife scalpel, but it's not. There was no significant difference was found between both techniques in terms of postoperative wound complications, hospital stay, wound cosmetic characteristics. Therefore, we recommend the routine use of electrosurgery for surgical incisions. And I started doing this before the studies really came out, because I was trying to avoid sharp instruments with residents. I wanted to and the last thing you need is to have a medical student get stuck or cut with an instrument in the oar. It's hard to explain those types of things to the dean. Okay, so here we're making electrosurgical incision. I'm using the cut mode. I use a wattage of 50. It might be kind of high. The studies I mentioned use a wattage of 20. Pure cut. And I had to prime it up a little bit here. You can see, as Dr. Champa mentioned, that resident is sucking that smoke. And in the routine for sucking the smoke, you follow along and you can get 80 or 90% of the smoke. Most of the bovies now have in Georgia, they made a law that we had to have some type of way to aspirate the smoke, and you can see the back of the cord has a suction device where you can suction away some of the plume. My frustration with this is that the suction doesn't start right away. I mean, it takes a while for it to rev up, so if you push the button and start using electrosurgery, you're still going to get some smoke to escape because the suction hasn't caught up yet. And this is a patient I did in May. She came back to me in August, and this is the way the incision looked. So it really doesn't look that bad. It was electrosurgery, 50 watt, pure cut. So transverse incisions. Here's a routine transverse incision. This is a phalansteal, which we're all very familiar with. And here the inferior epigastrics coming up laterally. This is a maillard. So a maillard is going to start off just like a fan. You're going to make your incision through your fascia here. This picture is courtesy of Dr. Baggish in his textbook. And here your rectus muscle. Here's a popsicle stick used to elevate the rectus muscle so you don't injure the intestines. And we used to use in residency, we used the Army Navy, and the Army Navy had a little area in it, so you can use your Army Navy with the bovie to transect your muscle to cut down on your blood loss. And this is the transected rectus muscle at the completion of your malar incision. And remember that your inferior epigastric vessels are going to be lateral. The next incision we'll talk about is a churn incision. And the difference between this one is that you're going to be transecting the rectus muscle at the symphysis pubis. So here, the dotted line is where you're cutting it away. This fascia is being retracted by this retractor here, and someone has a ridge holding it up here. And this is your parimerdalis muscle here. So this is a video of me starting a churning incision. At this point, the rectus fascia has already been incised, and I'm dissecting the parimerdalis muscle away from the rectus fascia inferiorly. The assistant is holding the fascia up for exposure, and here I'm taking my finger and I'm undermining the tissue between the rectus muscle and the peritoneum. I made a little defect there for my finger. Then she's going to retract. We're going to get the Mayo scissors out, and then we're going to retract the fascia away. They're going to use those scissors to cut the rectus tendon at the symphysis pubis. So here I am initiating the transection of the rectus tendon from the symphysis pubis, and my scissors were a little bit dull that day, but we're getting it accomplished here. So we come on across, and if you don't hear a crunch or feel a crunch, that means you're not in the right place. You're cutting muscle and you're not cutting tendon. I've come back to the other side. I'm struggling a little bit here because I'm trying to get the camera to see what I'm doing. I come back to the other side to finish it off. So there it's finished. Okay, now you've made the churning incision, now you got to close it. So here we're putting a suture in the rectus tendon here, elevating the fascia here. Excuse this poor technique of using fingers to retract, okay? But they're going to use our needle to catch the fascia right at the level where it's entering the rectus tendon. So the rectus tendon where it's in the symphysis pubis, I'm sorry. So there you go. So we pull that out, and then we tag it with a hemostat. And you're going to do this about 4 times. So now we decided to use good technique. So we brought a Richardson in. So here we got the top, got the rectus tendon. Now we're putting it at the rectus fascia, posterior inferior rectus fascia, and pull the needle through. And then we pop it off and tag it. And then we get ready to tie, and as I said, we're going to have a total of about 4 of these things. So then when we get through, we're going to start doing our ties. So here we are getting ready to do ties, and we're going to go down simultaneously so you don't have too much tension on one area alone. And the assistant is going down on one side, and I'm going down on the other. And that way, the suture is less likely to pull through the tendon. It'll never pull through the fascia. So again, you tie your knots down, good. We're using vicryl suture here. And I love the churning because you're generally not going to damage or injure the inferior epigastric artery. With the malar, generally you're going to transect the inferior epigastric vessels, so I prefer this over the malar because of that reason. And there's it completed, tightening it up a little bit. Okay, now this is the Ozelom incision. So it starts off as a fan, and you notice here the rectus muscle here, and here's the umbilicus here. So what's happened here is they've extended the dissection of the rectus muscle away from the rectus fascia. So this is the rectus fascia, rectus muscle, and they've just carried this up some more. And right here, this is going to be your transverse abdominis aponeurosis here. So when this gets closed, you have to be cognizant to close this because there's much written now about not needing to close the peritoneum, but we have to make sure we distinguish that this is fascia, it's not just peritoneum alone. that needs to be closed. When you get down here, you could potentially leave that open if you would like. And this is the oscillum incision closure at the end. Anterior superior spine is going to be here, and then it's the incision coming up superiorly bilaterally. Now, this is a patient that came to see me post-op, and you're probably thinking, God, what did he do to her? So she had an adnexal mass, and she had a transplanted kidney. So the kidney was on the left side, and I wanted to avoid that kidney at all costs. So I started off with a scope, but there were just too many adhesions for me to continue the procedure with a scope. So then I ended up going over to this side, and I ended up doing a hybrid low transverse incision with a paramedian. So we extended it up this way, and I was able to get exposure to the pelvis. It obviously started off as a retroperitoneal approach. We entered the peritoneal cavity, and I was able to deal with a mass and avoid the kidney. Now, let's start to talk a little bit about closure. So how should we close the fascia? This is the stitch trial. It was primarily conducted in Europe, but they had a large randomized series here. It was double-blind. It was well-designed, which is why I decided to include it into this talk. They started off with 609 patients to assess eligibility. They ended up with 560 randomly assigned, and then they ended up with 277 in one arm and 268 in the other. So these bites are not like the bites I was taught to use. I was taught to use these whopping big bites where you're getting at least 2 centimeters on each side with a vertical incision, with a large needle of a loop PDS, but that's not necessary anymore. So now they recommend that you use 5-millimeter bites or 10-millimeter bites. So generally a CT1 needle might even be too large, but generally that's what I'll probably use from now on to close this. I use a CT1 or a CT2. But large bites versus small bite group, and I looked first for this, the burst abdomen, and they had 2 in the large bite group and 4 in the small bite group, and I thought, well, that's not so good. But they've said that they did the calculation, the p-value was acceptable. The length of hospital stay was pretty similar, and the infection rates were pretty similar. So they recommended that we use large bites versus small bites, and then we always have to be cognizant that when you're putting the fascia together, closing that anterior abdominal wall, please make sure that the fascial edges are approximating each other. When you take the big bites, oftentimes you take the big bites and you'll see that there's muscle, but the fascia is not actually approximated. It has to be approximated. An obstetrician gynecologist review of hernias. So I got this from the Gray Journal because we all want to see something done by us versus by general surgeons. So they talk about laparoscopic also, and I wanted to put this in because the trocar sites that are large are going to be more likely to have hernias, and it's important that you close your hernias, not your hernia sites, but you close your large port sites. So any port site that's greater than 10 millimeters, you need to try to approximate the fascia. Ports at the umbilicus tend to have more hernias in the long haul. Also, ports in the umbilicus are thought to be more prone to infection, especially if the umbilicus is deep. Post-op wound infections, really avoid these. Make sure the patients get their antibiotics pre-op, because if patients get wound infections, they're more likely to get hernias down the road. Please avoid the wound infections. So if you think somebody might have a wound infection post-op, it's important to address it right away so that they won't be at risk for developing a hernia down the road. And of course, prolonged surgical time with laparoscopy. The longer you operate, the more torque you're placing on the port sites, and the more likely you are to get a larger, you start with a 5, but you might end up with a 10 with all the torque. The entry techniques really didn't show much of a difference at all. The fact whether the patient was diabetic, and again, it's laparoscopic surgery, so you're less likely to have wound infections because the incisions are so small. Now, this is a very involved slide to just tell you that Before surgery, you want to tell the patients not to smoke, and then you want to avoid large loop sutures. So the number 1 loop PDS on that large needle that needs to go. Make sure you take small bites, avoid your wound infections, and then if the patient has to go back to the operating room within 30 days, make sure you go with, even if you're going for even if the general surgeon is taking her, make sure you go back with them so you can explain what you did during the surgery and that the patient sees that you care about her. Schematic diagram on how to close. So this is a more traditional where you're going a little bit more wide, taking a more wide mass closure. Here you're looping around 2 centimeters, and then down here is what is recommended at the present time, where you're doing 1 centimeter bite or 5 millimeter bites. And if you want to do a mass closure, you can, but you're not going back on this very far at all. If you want to use delayed absorbable suture, 0 or number 1 PDS. But again, you don't want that large needle. You want the smallest CT1 or CT2 needle. There's also been some talk about using mesh, and I just can't wrap myself around this. But patients who are at risk for developing hernias, you can consider placing a mesh, either an overlying mesh or an inlying mesh. So an overlying mesh would go, quote unquote, anterior to the fascia, and you would suture the mesh down to the fascia. Or you can make it where you're going more intraperitoneal and the mesh is going posterior to the peritoneum, but you can imagine that you're going to have big risk for intestines becoming adherent to the fascia and to the mesh. So always think that patients are going to be at risk for having to get surgery down the road, so I generally would want to avoid a mesh that's going posterior to the peritoneum. So the US and Europe decided to get together and talk about guidelines for closed abdominal wall, European American hernia societies. So there are 3 or 4 big recommendations. Continuous small bite suturing technique for slowly absorbable sutures suggested for closure of elective midline incisions. And again, this is going to be PDS and not vicral, certainly not chromic or plain gut. I don't know if residents even know what chromic is anymore. You want to recommend that you want to avoid the midline incision if at all possible. And I talked about the midline, but you want to avoid it if you can. What goes around comes around, I guess. We were taught this back in the 80s, and it's coming back again. Try to do transverse incision. Even if you're having to get your pathology out, i.e. a large ovary, you still want to try to do it through a transverse incision so you can make a small fan just superior to the symphysis pubis. And those patients can still go home the same day because it's a small fan. This suggests that the suture the fascia defect for trochocytes of 10 millimeters or larger, as I mentioned earlier, especially after single site surgery, because there's going to be a lot of torque on that one site if a trocar is located at the umbilical site. Wound aftercare, and I never really thought about this much coming along, but patients who are prone to hypertrophic scars or patients who have keloids, you might want to consider injecting Kenalog. So I usually use 20 cc's instead of 10. You mix that up, mix 40 milligrams and 20 cc's of saline, 25 or 23 gauge needle, and inject it along the incision line before you make an incision. Moist wounds heal better. I used to think dry was better, but moist is actually better. It helps prevent dehydration of the wound. It's plus or minus whether you should use an antibiotic gel immediately post-op. You want to use an occlusive ointment, which can be a silicone gel or even petroleum jelly a week after the surgery. So you don't want to do it right away. You want there to get some re-epithelialization before you use this. The silicone sheets and silicone gel, vitamin C, again, you want to start this about a week after the surgery procedure is done. I've read about wound massage, but I couldn't find any really good, reliable data on that. And you still want to avoid the cigarette smoking if you can. I guess there are other good reasons to stop cigarette smoking also. And then sunblock. The patient's going to be outside in the sun. then you might want to consider sunblock at least a week after the surgical procedure to prevent the sun from coming in contact with the wound, because that'll make it more erythematous and more tend more to be hypertrophic and darker. Another strategy for this is just to put my pointer died. Another strategy is to put a Band-Aid over it if it's laparoscopic procedures, or a bandage if it's a more laparotomy procedure. What to take home: consider electrosurgery for making skin incisions, aspirate the plume. Some people think it causes cancer. If needed, convert a phalansteal incision to an Azalam or Cherney for more exposure. 5 to 10 millimeter bites in the fascia for vertical incisions. Transverse incisions are less restrictive about what you need to do to close them. Mask closure, still take small bites. And a good rule of thumb is you want the suture to be about 4 times the length of the actual incision yourself. And you can be, thank you, you can be super compulsive and measure it out, measure incision and measure the suture. But if it's not 4 to 1, you're not making your bite small enough. Keep your wound moist and covered, and then silicone jelly about a week after the surgery. I don't have any disclosures, but these are people I count to. This is my partners, Dr. Gaddick and Dr. Davis, and these are fearless leaders, Ms. Myenga in the SIM lab at NMA, and this is Kathy Bonk, teaching shoulder dystocia drills. Case studies, I got a little time. Remember the pyramid of surgery, understand why you're doing the surgery and what you're doing it for, select the right patient, and then perform the surgery correctly. Okay, you got a 28-year-old pelvic mass, 6-month duration. She thought she was just gaining weight, but it ended up being a large mass. And here is your CT scan pre-op. This is homogeneous, and let's say the house fill units are 10, just 10 units of house fill units. How would you think this should be approached? So we can't do it by vaginal route, so that means we're going to do it by laparoscopic. We're going to do it by laparoscopic or laparotomy. So would you approach it with laparoscopy or laparotomy? Okay, so I looked at this with the radiologist about 6 times, and there was no lymphadenopathy, no ascites, so I decided to approach it with a laparoscopic approach. And the first thing I did, I palpated the mass. The mass came all the way up to here. I palpated the mass. We had the CT scan pre-op, so I knew there was no intestines between the abdominal wall and the mass. So I just jammed this 5 millimeter procar into the mass. And then we were able to aspirate the contents from the mass. And that contents, clear water. I mean, it just looked like water. Then we're able to get our scopes and our trocars in, and this is the trocar inside the mass. The mass is decompressed, and then we were able to complete the surgery. The second case, 6 to 7-year-old pelvic mass. It's 6 centimeter complex mass, and it's been present for about 4 months, and she's been complaining of 6/10 pain. Her CA1 trend valve was elevated to 125, and she had remote, complicated colon surgery with a post-op leak. And she also had subsequent mesh hernia repair. So she's got mesh. I could almost feel the mesh at the umbilicus, and her BMI was 45. So how should we approach this patient? Should we do laparoscopy or laparotomy? Okay, we do laparotomy, and if we do laparotomy, what kind of incision should we make? Should it be vertical, paramedian, or transverse? And this is a little bit of a curveball here. So I decided to do a transverse incision, and notice that this is the transverse incision, this is the umbilicus here. And we ended up doing a paniculectomy because this would give me a lot more exposure. And you can see this sub-Q is about 10 centimeters in depth. We ended up taking the umbilicus also. This is the closure at the end of the case and drains on both sides. This is the patient at her 2-week post-op check, and the wound is slightly separated here, but she's doing well otherwise. And that's the end.
just stand next to me. Thanks so much, Dr. Spann. That was a great talk. If anyone has any questions, you can raise your hand, and we'll bring the mic to you. Yes, we have a question up front. And
Comments, too.
Or any comments. And again, those people that are online, you can either put a question in the Q&A box, or you can raise your hand online, and we'll call on you as well. Okay, I think the mic is coming up front. Right here, Kate. Right here.
Good morning. My name is Magdi Hanafi. Thank you, Cyril, for excellent presentation. And my question is that there is some modification of umbilical incision for laparoscopic procedure for larger uterus or larger fibroid tumor. And can you elaborate on that? I have a comment on that too, because I have a way of doing it was doing annular umbilical incision, where I do like crescent of excision of part of the skin in the upper fold of the umbilicus, about an inch thick, and about 2 inches long. And then I retract the skin for about 2.5 inches above the umbilical insertion in the fascia.
Okay.
And this way I can put the trocar about 2.5 inches above the umbilicus. And that will give me a better view for larger fibroid tumor, and I will be able to put the lateral trocars. Then I can not only see the adnexia and tube and so forth, because I do infertility a lot. But it's easier as well to extract the tumor through the umbilicus and then reconstruct the umbilical incision. Pretty easy, actually. And do you have any other suggestion or any other modification which you can help us?
I mean, I like your idea. I think I might try that, actually. But I started doing, at the beginning of the lecture, I talked about the high approach to laparoscope. And I started doing it that way because that's what we do with the robot. And it just worked well for me, so I started making them higher. For the younger patients who are really concerned about cosmesis, if I think I can do it through a fan, I might choose to do a fan for cosmetic purposes versus doing the laparoscopic procedure. That way they don't have any incisions that are visible.
But this annular incision still will be within the umbilicus, so it will not go higher.
Right, right.
And, but the fascia go higher, and
right.
Above the umbilical insertion of the fascia.
Yeah, I might try that, and then you get into the fascia. You can
work
avoid
very
the
well.
hernias.
Give you a very good view.
Yes, sir. Okay.
Thank you.
I see some hands in the back. Were there any others in the front? Okay, Kate, there's 2 that I see in the back.
Thank you, Dr. Spann, for an excellent lecture. There are a couple things that I will be changing in terms of what I do. I just, this probably goes without saying, but I'm going to say it anyway. The other reason to suck the smoke, other than risk of cancer to the operator, is the heat of the smoke can actually cause skin damage as you're making your incision. So good point to suck the smoke.
Oh, thank you. See residents? Okay.
And then in the back, I think Dr. Matthews, did you have a question?
Yes. Just wanted you to comment on when you use the robot versus straight stick. Is it just based on the availability of the robot?
Well, I'm fortunate that I have a robot day and I have a laparotomy or non-robot day. And the robot is primarily going to be used for patients who have a BMI over 40, or they've got op notes that suggest that it's going to be a difficult procedure. If I think I'm going to get lymph nodes, I prefer to use the robot. So far as teaching is concerned, I think it's more value to teach residents laparoscopic than robot. So I like to use the laparoscope to teach residents also. So I like to use the laparoscope a good bit too. The patient has a low BMI.
And Dr. Handy, I think you have a question?
I have a question. I had a colleague that used glue after they closed the incision. Is there any literature or anything benefit to using dermabond glue after you've done a subcuticular stitch closure, now you go over it with glue?
So I do that myself. I use glue. I don't have any data for it or against it. I think a resident told me I should use glue, so I started using it 15 years ago.
Any other questions?
Yeah, I do.
Yes, yeah, Dr. Scott.
Yeah. Do you do Varies needle with OptiView, or is there any advantage of doing both of those?
Yeah, so I use a Varies needle, one, because I think it's easier. Because remember, when you use the Varies needle, you establish a pneumoperitoneum, so you have pressure coming from inside out from the pneumoperitoneum. So that way, when you put the trocar in, you got pressure pushing out, and the trocar doesn't push away from you. I mean, the peritoneum doesn't push away from you as you're pushing the trocar in. Does that make sense?
Yes, it's an ease of doing it.
Right. So
But
it's
the
easy.
OptiView is sufficient. The safety with the OptiView is so.
So you mean using the OptiView without pneumoperitoneum?
Yes. I mean,
So you still have to be careful with that, right? So as
Yeah.
long as you know where you are all the time is good,
Right,
because you can
yeah.
get through. Some patients have what we call a buttery fascia. You can get through that fascia and you're in, and you're looking at omentum, thinking that it's
Yeah.
sub-Q. So you just have to. Be
Yeah, I don't take that approach, but some people are recommending that. I
Okay.
use Varies and then use the OptiView also.
But-
But some are advocating just going straight with the Opti.
But you work at Emory Decatur. Are you working with residents there?
Occasionally.
Yeah. So I mean, if you're working with residents, I think it's probably better to use get a pneumoperitoneum first.
Right. Okay. Thank you.
Yes, Dr. Fogel?
Are you using barbed suture at all?
No. So I used Stratifix on a vertical incision about 10 years ago, and the lady ended up with a hernia a year later. So I stopped using Stratifix based on the N01. So no, I don't. I've used it to repair bladders. I haven't used it to repair, I'm afraid to use it to repair bowel, but I've used it to repair bladders. And I certainly use it on the vaginal cuff.
Any other questions or questions online? No? Okay,
And
thank you.
you can call me or get me between